Thank you very much, Prof. Fariza. I don't even know that person you were telling them. Alright, okay. Assalamualaikum warahmatullahi wabarakatuh, and a very good afternoon, everyone. We just had lunch, so I hope I can actually take you through this. Alright, okay. So I've been given the task to talk to you about managing tobacco-related diseases, clinical cases, and treatment strategies. But I will tweak it a bit to when cessation fails the clinical price of tobacco, because we know that this is a tobacco track, yeah, and we'll take it to clinical, and we will see how does it, impact not only the patient but also our healthcare and also the economy. Right, okay, so unfortunately the first was supposed to be the third speaker, so this would flow, but unfortunately it becomes the first one, but never mind, we'll just go through it. Right, okay, so this is the presentation outline. I will have two cases. One is COPD and another one is non-small cell lung cancer. These are the most common cases or diseases related to tobacco. Yeah? Then after that, we will conclude. Okay, so I'll present to you the first case. This is a case of the missed opportunity. Mr. L.A., a 71-year-old gentleman. He's a chronic active smoker with 55 years history. Yeah? Background with diabetic, with end organ damage, IHD with post-CABG, and he also had a prostate cancer, and he underwent radiotherapy. So he has been diagnosed with COPD, GOE. We will go through the GOE guideline, yeah? MRC 2, meaning his performance status 2. He can still walk but very slow, he doesn't go out very much, and he had 2 admissions for the past year. So if you look at this man, he's not very productive, he can't do much, he cannot go out anymore, not very much socializing, and he had been admitted. Yeah? So with every admission of COPD patient, then the baseline of their lung function will decrease, yeah? And it's like a vicious circle. Then their general condition will rapidly go down with every exacerbation. And during assessment, he's still able to carry out his daily chores in the house slowly, no longer going out. But again, he is non-compliant to the treatment, plus he was still smoking. Okay. So if you look at the X-ray, that is a typical X-ray of someone with COPD. They are hyperinflated. You can see if how many medical students are here? And okay, never mind. You can count the ribs. It's more than 6. Yeah, going back to our medical time, and we had done the spirometry for him. You look at the post bronchodilator, so it is less than 70%. So this is a confirmed case of COPD, right? So what do we know? We will go through this, then I will tell you what are the treatment later. Okay, COPD in actual fact is increasing. Yeah? In Malaysia, we know that it is about 10%, but it could be under, the number is lower than what is the actual, because we do not have a registry, so we do not have a proper statistic. But worldwide, it is actually the 3rd leading cause of death. Yeah? And in low middle income, it is actually the 90% cause of death. Yeah? But again, as I have told you, we do not have the statistic. Not everybody being screened, so over 70% of COPD remain undiagnosed. So what happened? Okay, what you have to know is that when the smoke, either from cigarette or whether it is from your vape, it goes in, there will be inflammation. Yeah? So what happened? They can have bronchitis and also they have emphysema. It doesn't happen like today you smoke and tomorrow you get all this. No, it'll take time. The minimum number is actually actually 10 years. Yeah? And what you have to know as well is that when you have this inflammation, it's a systemic multimorbid syndrome. Yeah? You know that when you have a patient who is a smoker, not only they can have COPD, but they can also have IHD, and now diabetic is also being put in as well as one of the inflammatory diseases. So they can have the whole jingang of all these diseases. Yeah? And usually they have common comorbidities again, the cardiac, the metabolic. Yeah? So sometimes some of these patients would get COPD, maybe not from smoking, but they have a genetic predisposition for it. But if you are a smoker and you have a genetic predisposition, so these diseases can actually happen much earlier. Yeah. So again, the aging process is another thing that you have to take into account. Yeah. Okay. Do not tell the what you call the smokers, but in actual fact, out of all the smokers, only 16% will get COPD. But 90% of this, the COPD are smokers. So, you know. Okay, so how do you manage a COPD patient? Number one, you have to know their symptoms. And when they come in, they are breathless. Yeah, they can come in with wheezing, yeah, and coughing as well. So how do you know whether is it asthma or is it COPD? So those are the two things that usually come in with breathlessness, wheezing. And when you have asthma, it will actually, it is actually episodic. But when you have COPD, it is continuous. Yeah? So those are the difference between COPD and asthma. So asthma, usually there is a trigger, but COPD will just continue on. Yeah? So you need to know what are the risk factors. If someone is a smoker, it needs to be more than 10 years. If it's less than that, then you have to see whether is it asthma or is it anything. And you must do a spirometry. If you look at the gold guideline, it will say that the spirometry FEV1 over FDC must be less than 70% or 0.7 before you diagnose a COPD. So once you have diagnosed the COPD, then you have to assess this patient. You have to look at the airway, whether it's goal 1 to 4, yeah, whether there is an obstruction. Okay, then you look at their symptom and you look at the exacerbation. And other than that, you look at the smoking status, blood eosinophil, alpha-1 antitrypsin if they have a genetic predisposition, and also comorbidity. And if you look at the initial management, on top of it is actually smoking cessation. You must actually advocate smoking cessation for this patient. But is it easy? No, it is not easy. Because they have been smoking for the longest time. Those are their best friend, the cigarette are their best friend or the vape. Yeah? So you have to advocate and you cannot actually give up on that. Other than that, I will go through that. Then subsequently, once you have initiated treatment, then you have to review and see whether you have to escalate the treatment or you can just continue the treatment. Okay, so this is gold guideline says that spirometry is actually mandatory. But what is, despite this guideline, in Malaysia, spirometry is only available in less than 50% of clinic kesihatan. Yeah? And GPs, even, not many GPs are having it. And if they do have it, whether they can actually do it properly. Because it is, okay, ECG is difficult. But as long as you know where to put it, and it is correct, then it's okay. But when you do a spirometry, you need to coach the patient. If you do not coach the patient properly, and they do not do it at their best effort, then your spirometry will be useless and you cannot actually interpret it. Yeah? So you need to have the spirometry. Where can you send them for spirometry? You do not have to send the patient, but you can refer for spirometry at any respiratory centers, or you can actually ask whether the KKs. Some KKs do have it. And now we are going into getting the KKs with spirometry. Yeah. Okay. So once you have the spirometry, then you look at the whole ABE assessment. Number one, that you have to see, okay, it doesn't matter. Spirometry confirmed, then you can forget about it. What you want to know is exacerbation. Okay. The exacerbation is moderate to severe. Okay, what does moderate mean? Moderate means that they go get the nebulizer, or they are being put on penicillin or antibiotic, but they do not have to be admitted. Severe means they need admission because of the COPD. If they have any of this, then it is already gold E. That is the category that we put. Yeah? But if say they do not have it, then you look at their performance status. There are two performance status. You can use the CAAT or MMRC. MMRC is much easier. You look at their functional status. If they are breathless, even walking a short distance, then it's more than 2. So it will be B. Why is this ABE assessment very important? Because we use this on the initiation of therapy. Okay, so I've already mentioned this. Okay, so this is the initiation of therapy. So when you start the treatment, you look at which group are they and what would be beneficial for them. So as the initial treatment, you will put them on lama-lama if they are already in group B, meaning there is long-acting beta agonist and plus long-acting muscarinic antagonist. Yeah. So when they are on these two, meaning they are on double bronchodilator, long-acting bronchodilator. Yeah. So after that, then only you reassess when they come back and whether there is a need for you to start them on ICS. Not all COPD patients need to be on ICS, except those who are continuously exacerbated despite being lama-lama, or their blood eosinophil is very high. So this is in goal guideline. So you have to identify and reduce the risk factor. So the first thing is smoking cessation, and it is evidence A, meaning the evidence is very strong. Yeah? So you must stop, you must get them to stop smoking. Some of the medication doesn't work very well when they are smoking. Okay? So what are the other medication or management for non-pharmacological? Okay, you have to give them vaccine. What vaccine? Okay, influenza, pneumococcal. Influenza yearly. Pneumococcal, if you give Prevnar and pneumococcal 20 now, yeah, then you give one off, then that's it. Yeah, but follow the immunization guideline for adult, SARS-CoV-2, COVID, RSV now, yeah, and Tdap and also zoster. So in KKM, usually we will give them influenza and pneumococcal. If they can afford, then we can give them RSV and Tdap and zoster. These patients, even at early stage, should be put on pulmonary rehabilitation if they are breathless and their oxygen is low, and we look at we assess them. If they need oxygen therapy, they can put on long-term oxygen therapy. Right. Ventilatory support, usually in Malaysia, we don't actually put them on ventilatory support at home. Yeah. Because it is not easy. So we have to really sit down, discuss, not only with the patient, but the family who will take care of them. Because sometimes when you put them on ventilatory support at home, what happens, they go home, they do not have the suction, they do not have anybody doing the chest percussion. Actually, they will not die of the COPD, they will die of pneumonia. Yeah? So the family need to know what to do and what to expect. Yeah? So if the patient is fairly well, you can do intervention and surgical treatment for this patient. Yeah? And another one is self-management and education. The patient needs to know what to do, and they need to take care of themselves. So what did we do? So this is the detection gap. So what we must know, COPD is the third leading cause of death worldwide. 70% remain undiagnosed, and our gap is actually our clinical responsibility to close. Yeah? So spirometry is mandatory. So look at the post bronchodilator, and the goal every is to guide us on selection. Yeah? So what did we do with Mr. LA? Yeah? So because he is non-compliant, we check again his inhaler technique. Inhaler technique must be checked every time, yeah, at every visit, and we gave him pneumococcal and influenza, but we didn't give him the RSV and SARS. This is the ideal thing. Okay, of course, the smoking cessation, we put him up for our quit smoking clinic. We put him up for pulmonary rehab, and we addressed the non-compliance. Yeah, so that is the whole scenario of the COPD patient. Okay, so we go to the next case. Okay, same smoke. Sorry, it's not different organ. It's the same organ, but it's a higher state. Right? Okay, so case 2, Mr. LSH, 68-year-old gentleman, okay, ex-smoker, 60-year history, presented with hemoptysis associated with dyspnea. Okay, ECOG 1, ECOG is another performance status. This is Eastern European, I can't remember the whole thing, but it's basically for lung cancer. So ECOG 1 or cancer for that matter. HPE came up with after biopsy, adenocarcinoma. IC, TTF1 and hepcin A is positive, meaning that it is of lung origin. Yeah, EGFR, the oncogenic mutation driver is positive. He is lucky. Yeah. Exon 21 L858R mutation. Why do I say that he's lucky? He can actually take oral medication. Oh, okay. Okay, so what you have to do is CT staging, and it's not only lung, but you have to do the abdomen and pelvis. Yeah? If they are symptomatic, you have to do CT brain. So the diagnosis after the biopsy, if you look at that, yeah, there is a mass there. Okay, there is also several masses there. So it's non-small cell lung cancer, stage 4B. So it's advanced stage. Okay, so this is the epidemiology. This is from our National Cancer Registry. Okay, we are still top. Yeah, lung is still top. We are the third. Yeah, and on top of that, about 90% are actually presented stage 3 and 4. Okay, they're asking screening. We had done a study, but not many want to know, unfortunately. They would rather not know that they have lung cancer and continue smoking. So we have to advocate for all this, right? Okay, so this is what it is now. When I was studying, long time ago, okay, there was only two, much easier. Small cell, non-small cell. That's it. Okay, now small cell, non-small cell, after non-small cell, adeno, squamous, large cell. Then subsequently, you need to know, okay, you need to know all the oncogenic mutation. Yeah. So from here, you look at whether there are any of this that targetable, or whether they have medication, then you give them accordingly. Yeah. Okay. So this is how complex the current management is. So for our patient, okay, so he had adeno, he had driver mutation, and he was EGFR. So if you follow this is the PAN Asian ESMO guideline. So the first line is osimertinib, but osimertinib is very new, it's third generation, and it's very expensive. Yeah, about 18,000 per month. Yeah, so initially we could not give him osimertinib. So we started him on gefitinib, the first generation, which cost us about 1,000 over per month. But unfortunately, he developed rashes. So it is not without side effects. Yeah, any medication will have side effects, but he had a great deal side effects, which is very severe. This is from the article. So he will be here. The face and all would be very, very bad. Yeah? So it was stopped and treated, and subsequently we had to change it to the third line, which is much more expensive. He's doing well at the moment. Okay, these are the common toxicities of the EGFR. Yeah? So we have to treat this. Some patients could not tolerate at all. Yeah? So for case 2, what we did was EGFR mutation confirmed, non-small cell. We started him on treatment, but he had adverse event, so we switched to osimertinib third generation. Yeah. So if you look at this, lung cancer, yeah, 78 to 80% or up to even 90% comes in with presents with actually the stage 3B to 4. So what do you all have to do? We have to recognize, we have to quickly actually detect and refer for investigation. Yeah? Because if the later it is, the poorer their prognosis. Okay? So let's look at this. Okay. If you look at the smoking cessation, okay, this price is quite high, 4,000 ringgit. This is in ringgit, yeah? Okay, 4,000 ringgit, but this was from UMS study. And it is included with all the investigation as well. But it is still cheaper than COPD management, which was 9,000. And this is yearly, 9,000 yearly with admission and also the clinic visit. And plus indirect, meaning that their travel, their time off work, their family time as well. But for lung cancer, this is treatment alone. Yeah? It is about 144, 72 to 144. So it's staggering. So imagine if we have, my center have about 40 cases of lung cancer that we are currently treating, and about 20 of them are on TKI, and 10 of them is on osimertinib. So we are spending every year 10 times 18, 180 per month. One center. So that's the staggering number that we are dealing with. Yeah? So the best thing to do is to get them to quit smoking. It's easier for our pocket, it's easier for our taxpayer, and it's healthier for our nation and the patient. Thank you very much.